Hello, I'm Manoj Karmakar. Welcome to issps TV. Through this channel, we hope to bring you quality education in regional anesthesia. If you like any of our videos, then do remember to click the like and share button. If you are new to our channel, do remember to subscribe so that you can get regular notification of any future uploads. So now we will go into our Q&A. So I'd like to welcome our moderator, Dr. Louis Mock, to come in at this stage and moderate the Q&A for us, please.
All right, thanks, Dr. Kamaka, and all the other panelists for the very enlightening lectures. Now we're just going to go through a couple of questions, and I saw that some of them have been answered in the Q&A sessions, but perhaps the other members in the audience would like also to know some of the answers to these very intriguing questions. A couple of questions actually evolved around the incidence of the subdural injection. There are two questions related to that, both directed to Dr. Rayner. The first one is whether the use of larger bore 16-gauge 2E needle in epidural might reduce the incidence of subdural injection. And the other is which approach, whether the paramedian approach or the midline approach is more likely to enter into subdural space. So I'm going to direct these questions to Dr. Rayner.
The possibility of access to subdural space using a median or paramedian approach is similar, but mainly depend the large stent effect against the dural sac, but depend the advanced velocity the needle when you perform the epidural technique. It's very important and slow advance at last time of this technique to avoid this 10 effect, this large 10 effect, because when you perform a puncture with spinal needles, bevel or pencil point spinal needle produce a simultaneous superimposed lesion on the dura mater and the arachnoid layer. But when you use the 2E needle and epidural needle with the rounded edges of the orifice, produce the piercing of the dura, but not the piercing the arachnoid layer at first time. When you advance the tip of the 2E needle, produce that detach and push of the arachnoid layer, giving origin to the subdural space. But using a paramedian or median approach is similar.
Thank you. So I gather that the approach didn't matter as long as the needle advancement is taken slowly and to prevent the absolutely to prevent the tenting of the dura in the procedure. Thanks a lot, Dr. Rayner. Another question to Dr. Rayner and also Dr. Bernard. It's in regards to the gap in the ligamentum flavum in the midline. So there is a member in the audience who would like to clarify whether this will confer an increased risk of a dural puncture because of the perceived lack of ligamentum flavum at the midline if the epidural is performed in the midline manner. Would a midline epidural insertion be more likely to lead to dural puncture because of the midline defect. What do Dr. Margot and Dr. Rayner suggest?
Okay.
May I answer first?
Yes, of course.
Of clinical relevance, these gaps are only true in sense of having no loss of resistance if you are strictly in the median between those two parts of the ligament, and if the gaps are rather big, as I showed in one example on the right hand bottom side, then that may be clinically relevant. Otherwise, very often you're actually, practically speaking, not always quite in the median or in the middle between those two parts. So it may play a role, but I'm not aware of any study that says it has this or that clinical relevance. What's the truth that I mentioned during my lecture is that the more caudal you go, that means the more towards the sacrum, the less frequent are those gaps.
Mm.
And it's a quite different thing than in the thoracic spine. This will be shown in 2 weeks when we talk about the thoracic region. Because we did, actually, to inform you,
I will go to the live demonstration.
the study on gaps was in my department. So we did all those specimens.
Okay, I will say I will go into the live demonstration.
Yep, thanks. Sorry, Brian and Manoj, could you just perhaps mute yourself? All right.
Sorry about that.
Thank you. So, all right. So let's now move on to Dr. Shi. There's a question regarding the best technique to identify or to verify the positioning of epidural catheter. Can you perhaps suggest a modality of imaging that would be suitable to verify the position of an epidural catheter?
Okay, thank you. Assuming you're inserting the epidural catheter with fluoroscopy, it's important to record and mark where the tip of the catheter is at the end of the day, and of course confirm this with a bit of contrast injection. Keep that image because that's what we on the radiology side have to use for our comparison when you're doing follow-up studies. So currently my anesthetists usually send for MRI, and you usually should be able to make out the appearance of the tip of the catheter and follow it all the way up. Sometimes it's difficult, especially if there's scar tissue, for example, surrounding it can be difficult. But I think MRI is probably still the way to go. I think CT has too much radiation for the purposes of follow-up. Yeah. Right. Yeah, it's a good question. I think if you have the primary image, that the one that you use to at the final placement, and then we use that to compare with the MRI, then we can make a judgment of whether it's migrated or not.
Thank you. Thank you. And if Dr. Kamaka is around?
Yes, I'm around.
Yes.
Although you can't see me.
Yes,
Some technical issues.
There is a question in regards to ultrasound assessment of the lumbar spine. So this member of audience would like to know whether you would be able to identify lumbarization and sacralization of the lumbar spine.
Of course.
And how could you do so?
I think I will leave that question to Bernhard.
Okay, thanks. As I said, these variations in the lumbar sacral area, they're really relevant, especially because there is complete and partial and a lot of things that you have to know. The easiest thing is to start at the sacrum and look for the dorsal sacral foramina, okay? They're always visible with ultrasound. And it depends on how much of those foramina you count. You can estimate which is a sacralization or lumbarization. And if you look at both sides, you will always find in such cases there's more fusion on the one and less fusion on the other side. but it takes a lot of experience to differentiate the whole thing. So the answer is yes, it is possible, but not starting at the lumbar spine. Start at the sacrum. Evaluate the dorsal surface of the sacrum very carefully. Count foramina, and then you get your picture about those variations. And at the very last thing, I showed you one slide. I hope I didn't mention it. Some of you might have recognized that there was only 4 lumbar vertebrae, because the fifth was part of the sacrum. So in addition to the very detailed analysis of the sacrum dorsal surface, you do at the second step from above downwards. That means from L1, which is easy because you can easily identify the 12th rib and know what is 12 and what is 1, and then count downwards, and those two things together give you a picture about sacralization. So it's a very it depends on your ability to differentiate osteostructures.
Kenneth, would you like to say something about it?
Yeah, sure. Certainly on the MRI or the CT scan, the way we number the lumbar vertebrae is with reference to C2. So while we do a block at the bottom for the lumbar spine MRI, usually what the techs will do for us is they will open up the whole field of view and scan right from the craniocervical junction so that we can see C2. And then we can count it all the way down to the last unfused segment. And that's how we tell. That's based on the MRI. For CT scan as well, that may be a bit variable. And Professor Bernard is right. You have to then do your own analysis, because it depends. You need to speak to your radiologist and establish some kind of understanding at an institutional level. So for example, if you have a X-ray of the lumbar spine, you're not going to be able to count from C2. So you won't know what is the last unfused segment. You just assume that based on the last rib being at T12 level, whatever comes below T12 must be a lumbar vertebra. And so the way we would normally say is counting from the sacrum, the last unfused segment is L5, for example, or L4. Something like that. That's for the cases where we don't have a C2 vertebra to count down from.
Well, but there are variations in the T12 also, right?
Yeah, right. Bernard? For example, the worst thing that you can get, and I have experienced that once in a patient that had a lumbar rib and a sacralization of a lumbar vertebra. So you're at the first step, you're completely confused because you start counting, and then you say, oh, this is rib number 12. In fact, it was a long lumbar rib, which, by the way, happens more left than right. So it's sometimes challenging, but you have to have all those things in mind to not to get confused.
Thanks. Thanks for your answer. Maybe we'll just go for one more question if we have time. It is actually a question of general interest, and this participant would like to know, when do you teach your residents to use spinal ultrasound? Just because this is used to be considered one of the more advanced skills in the use of ultrasound. So do you have any practice preference or in your institution?
So the first thing, when I may answer, is you have to have an experienced guy on your side, otherwise you probably will never get much success. A second thing is, as shown in many institutions, a lot of people rely on plastic models of lumbar spine or the whole skeleton. This is a good thing to train, but it's nothing to prevent you from errors in the daily practice, because if you have the possibility, and I'm in a happy situation to have real skeletons, best hundreds of them, to compare them, then you will get really experience in that field. But the most important thing is having somebody teaching you the right thing on the right patient in the right place.